All right, well, it's a little after 2 o'clock and we can go ahead and get started, and I will admit people as they come in. My name is Laura Lane, and I'm the Deputy Director in the Office of Women's Health at the Georgia Department of Public Health. And unfortunately, Kimberly Ross, your fearless leader, is out today. So I'll fill in for her and just welcome you all on her behalf and on behalf of the Neonatal Committee. And thank you for joining today. And I will turn it over to Claire Eden to get us started.
Okay, I'm hearing a lot of background noise, but I'm going to just carry on. Kimberly asked that we share that the Georgia PQC website has been updated. You can visit it at georgiapqc.org. And if you go to this extra part, then you'll see all the webinars that we've recorded that are on Train are also available on the GaPQC website. And we'll also be adding other resources as time goes on. So make a point of checking every time you come to a webinar. Will be a good reminder to come check out what's been updated on the website. So our presentation in terms of our education portion today is on keeping mothers and babies together to optimize outcomes. And I'll be presenting it along with my partner in crime, Dr. Deb Taylor, who is with Kennestone Regional Medical Center. She's core faculty on the OBGYN residency program and also the medical director of the WellStar OBGYN clinic in Marietta. So welcome to Dr. Taylor. And then I'm Claire Eden. I am a lactation consultant and I direct the EPIC breastfeeding education program out of the Georgia chapter of the American Academy of Pediatrics. And a lot of you have, we've been able to meet a lot of us together. So I'll go ahead and kind of get us rolling with our presentation today. So in September, we heard from the Gwinnett medical team about the importance of the golden hour, which is also, as a reminder, the recording is available on Teams and on the website now if you didn't get to see it. Thank you again to the Gwinnett medical team for Northside Gwinnett for presenting that. So rooming in when possible during the perinatal period and then working collaboratively to keep mothers and babies together when one is discharged without the other is important for many reasons, but particularly for optimizing and preserving lactation and breastfeeding. So we wanted to just kind of pull that thread over from our golden hour program and all the important benefits of skin to skin. And how those tie into mothers and babies rooming together during the hospitalization or when one or both of them are hospitalized and how that leads to our best outcomes. So commonly when we're talking about maternity care practices that optimize breastfeeding, this is called rooming in, but rooming in doesn't only apply to that very first healthy term baby is there for 24 to 48 hours. We're going to kind of expand on that today. But when mothers and babies are together, there's better outcomes. It optimizes opportunities for skin to skin. There's better temperature regulation in the infant, better oxygenation of blood sugar levels, and of course, opportunities for better bonding. Babies who are separated from their mothers sleep less and cry more. Rooming in is necessary to enable mothers to practice responsive feeding. Mothers can't learn to recognize and respond to their infant's feeding cues if they're separated. When the mother and infant are together throughout the day and night, it's easier for the mother to learn and recognize feeding cues and respond to them and create that confidence feedback loop. And then this, along with the close presence of the mother to her infant, facilitates the establishment of breastfeeding. It optimizes opportunities to learn to breastfeed, which are really important for parental confidence around breastfeeding. Okay, I'm going to hand it over to Deb. Yeah.
So when we talk about rooming in, we want to make sure that we're looking for safe ways to make this happen, both for our moms and for our babies. And some of that is about setting the expectations of what it looks like in that first 24 to 48 hours. You know, we want to make sure that the moms know that we recognize that they've had a long evening, they've been pushing, they've had surgery, sleepiness is normal and it's expected. And we want to help them find ways to work around this. You know, if they did have surgery, then we want to make sure that we tell them we recognize that they're not going to be able to get up as easily or as fast with a C-section, you know, that we recognize that the pain medication they may be on for their surgery can impact on their awakeness, and that we are looking as staff to support ways around that. You know, call for help when you need the baby to get out of the bassinet to you. Time feedings around pain medicines. And in that expectations or setting expectations, we really have the opportunity to develop processes with our nursing staff, with our lactation consultants, with our OB providers, where we are looking for and trying to minimize the possible risks to mom or baby from rooming in. So talk to them about what we expect and how we're going to work around it. You know, this patient is brand new out of a C-section. She's got Duromorph, she's got a PCA. I know as a nurse, I'm going to have to be in there more often to make sure she's okay to help with the baby. And that can segue into hourly rounding. It is our practice pattern that we go in and we check on these brand new moms and babies on the hour to make sure there's nothing we need to assist with. Some of that is family education. How can we loop in the support person or persons that are in the room to help mom be safe in taking care of baby? And can we limit staff interruptions as well as family interruptions at key points during the day to really help mom get the rest that she needs to be safe? You know, selfishly, COVID was nice from an OB provider because I didn't have to worry about mom and auntie and grandma and other auntie who all have opinions and are in there keeping my patient from resting. But as we've seen our hospitals reopen, we kind of have to segue back into how do we manage that visitor interruptions. And you know, we know that there are situations where being together 24 hours is not possible. In a perfect world, everybody would have the opportunity to room in, and to be honest, breastfeeding would be an easy and we'd have no challenges, but we know that that's not a case. Specifically, as we look in current practices with our obstetric community, we are seeing older moms with more medical conditions than I ever saw 20 years ago when I was training. For instance, sleep apnea. I never had a mom with a CPAP when I was a resident, and now it's very common for us to see patients bringing in their own machines. Preeclampsia also seems to be on the rise, and if we have people who have severe features who are on 24 hours of MAG post-delivery, that definitely impacts on their ability to function well with the baby. So as we're looking for safe ways to implement our rooming in, we are not naive to the challenges, but we think that lets us have an opportunity to really make decisions on our specific patient's condition and goals.
Whoops. I have a very sensitive mouse here today. Okay, so home hospitals, it's important to kind of weigh as we're talking about safety and also patient preference. It's important to keep in mind that while our patients are also consumers of healthcare and are making choices about where they get their healthcare, we need to remember that hospitals are a medical setting. And when it's safe, the best option for both mother and baby is rooming in and regular opportunities for skin to skin throughout the hospital stay. We, as healthcare providers, are obligated to provide care during that really critical period after birth, and that includes a lot of teaching. And I have said this over the years, you know, someone who just gave birth and someone who is a newborn baby are not necessarily ideal learners in terms of this consuming really formal didactic teaching, like we're delivering to you today with words on a screen or in a handout. But they are really uniquely primed to learn from each other in sort of non-didactic learning methods. So we kind of want to focus today, a period of this presentation is around there's so much teaching that needs to go on. We're going to focus on the like infant feeding angle of it. Of course, there's so many other topics that have to be covered as well. But when there are a lot of topics, I think infant feeding from a safety perspective is really critical in terms of like making sure we don't kind of slide on hitting all those safety points in infant feeding. Because we want our whole objective in this initiative is to optimize newborn nutrition, and that can look a lot of different ways. So in terms of teaching opportunities, we want to kind of think about the good old days where we said, are you breastfeeding or bottle feeding? And there's now becoming, which is a good thing, there's a huge variety or spectrum of choices in between those two things. So a parent's feeding intention could be either or both or some combination. And a parent's feeding intention should be, of course, first identified and secondly honored whenever humanly possible. New parents deserve evidence-based education around their feeding choice. And rooming in is essential to provide enough opportunities to cover all of the teaching that's involved with safe feeding. And we also want to involve the other parent or the grandparent, whoever the family consists of who's going to be caring for the baby. And also using the infant as sort of the main teaching tool, because like I said, mothers are primed and any caregivers are really primed when there's a new baby to learn from them. So from a responsive feeding standpoint, which applies to no matter how an infant is fed, this also referred to as Q feeding. It's important for all parents to learn about, even if they're not planning to breastfeed. Overfeeding can be a real risk from a safety standpoint and can also, of course, lead to childhood overweight and obesity. So parents should be looking for rooting and moving of the baby's mouth, not waiting until the baby's crying, which is considered a late sign of hunger. There's lots of great handouts on Q feeding and kind of demonstrating with pictures, which parents really like. And then considering the role of the pacifier. Pacifiers, of course, have long been used to soothe upset infants, and they serve a therapeutic purpose, such as reducing pain during procedures where the infant can't be breastfeeding or skin to skin. And they've been shown to reduce the risk of SIDS. But pacifiers can replace suckling and reduce the number of times that an infant is stimulating the mother's breast physiologically, which can lead to suppressed lactation and milk production. So it's important to spend time reviewing the role of the pacifier among newborns, that it isn't being used to postpone feeds, and that parents recognize the baby's able to give a chance to demonstrate those feeding cues, and providing teaching around the pacifier as a judicious use of a pacifier in reducing the risk for SIDS. Okay, so another opportunity, in that spectrum for families that are choosing to formula feed, they need, of course, information on, especially during this recent formula shortage, on where and how to procure formula, whether they need a WIC referral or not. They need evidence-based information on preparing formula safely, when to use ready to feed, how to store and prepare powdered infant formula. And of course, the huge variety of brands and types of formula, making sure that they have those discussions with their pediatrician, and that their pediatrician is centered as the expert in this area to discuss making decisions about brands and types of formula. And bottle feeding, whether it's formula or express milk, all bottle feeding parents need information on appropriate volumes. Of course, a 2-hour baby needs a different volume than a 2-week-old baby. When I meet with families in my work, I often hear that they didn't get any information about appropriate volumes in the first few days, and making that shift as the baby gets, through the first week and through the first month. They need information about how to pace the feeding to be safe, nipple flow rates, and then of course cleaning feeding items is really important in terms of what education parents are being taught about how to clean feeding items, no matter what's in the bottle. All right. Yeah, I'll turn it over to Dr. Taylor.
So in kind of the same vein, it's not breast or bottle anymore. One of the things that I see more and more often in my practice is this feeding of expressed milk instead of directly latching the baby on the breast. Now, sometimes expressed milk is the best option we have because moms or babies have to be separated. My twins were in the NICU and I couldn't be with them for 24 hours, or the babies have medical or structural problem like a cleft lip or palate that makes it difficult for them to feed directly. And then some patients just choose not to want to direct breastfeed. And the good news is that we know so much more about feeding expressed milk that even without direct contact, patients can be successful in having exclusively fed breast milk fed babies, even without the latching. So one of the places that we start with our teaching is hand expression. Now, I am a belt and suspenders kind of gal, so I love having a backup plan. I teach my patients about hand expression in particular in the beginning because colostrum is so much thicker and works so much better with hand expression than it sometimes can with a pump, particularly if it's not a medical grade pump, particularly if it's a pump that somebody got from their sister or they bought off the shelf at Target, right? It's also really nice if you have an electric double pump, heaven forbid, you can't find an outlet or the battery goes out and you have to empty your breast. Hand expression is a great tried and true backup model. So definitely a skill. There's a great video from Stanford University. If you guys haven't seen it, I highly recommend it. I make all of the fathers watch it so that they can be involved in the express milk feeding. Another thing to piggyback on what Claire was just talking about is the expectation around volumes. Not only does a 2-hour-old infant need a different volume than a 2-week-old infant, but the amount of chest milk that can be generated by breasts is very different 2 hours after delivery when we're still waiting for that lactogenesis to kick in versus 2 weeks after the baby's delivered, or even 6 months when the baby's been starting solids. So having a good discussion about what volumes they're supposed to be seeing or they ought to be seeing sets up our parents for success. Another thing that comes into play when we're talking about expressed milk is in the storage and preparation. Much like Claire was talking about with formula and the safe ways to prepare it, we know that cleaning breast pumps and cleaning the storage devices that we use is very important. If you have the situation where mom and baby are separated because baby's in the NICU, then there needs to be a sterilization process that happens with the pump parts and the storage. If you have a mom that's back at work and it's a 6-month-old baby that's now picking up everything on the floor and putting it in their mouth, in addition to the solids and the breast milk, maybe your cleaning doesn't have to be so strict, but it's important to have that conversation. When we look at all of the different types of pumps, you guys know as well as I do that the pumps on the market are amazing. We've gone from the wall pumps that plug in and only can do one boob at a time, or those manual pumps, y'all remember, to wearable pumps like Christy Teigen has that sits in your bra that my patients often have with them. So what type of pump is it and what's the goal? If we really are talking only about expressed milk, we probably need to be looking at a medical grade pump like the Symphony or one of the plug-in pumps. And if we're just looking to express milk when we're temporarily separated, then maybe we can get away with a Walmart or a Target brand or something we got off Amazon. Regardless of whether we are direct feeding or feeding expressed milk, one of the biggest important parts is making sure that the breasts get emptied on a regular basis. The first thing I ask my patients when they tell me they're worried about supply is, how many times a day are you emptying your boobs? Because if you don't ask, you're not going to get what you need. So talking to them about how to use the breast pumps, how often to use the breast pumps, how the breast pump works. I occasionally will have patients bring their pumps with them to the hospital if we know that there's going to be a separation, or if they're struggling with supply, bring them in the office, because I can't fix it if I can't touch it. So making sure you know what pump they're using and that they know how to use and operate. And then the last part we just kind of talked a little bit about already. In addition to the storage stuff that has to be cleaned, cleaning the pump kits. Almost all of the NICUs have those sterilization bags that come that have the little hash marks that you can keep track of how often you've used it, and that they tell you how often they can be used it. So just being mindful, and in your teaching on the unit, making sure that you take time to help mom work through all of the pieces and all of the parts that have to be cleaned while she's expressing her milk for the baby that she's separated from. And then it's back to the Q feeding, right? We really want to have our patients room in, because it is much easier. Like if I'm telling you, you need to empty your breasts every 2 hours, that means putting on a clock. Or you can just watch this really cute baby, and when they start smacking their lips or rooting, you know that it's time to empty your breast again. Positioning and latching, this is one of the places that I find our lactation service in the hospital to be so great, because they have so much more time than I do that they can sit and they can try. Everybody thinks about cross cradle as being the way to hold a baby, but football hold is so easy and so great for some of my post-op patients. So having a good lactation service that can come in and spend that time not only on the positioning of the baby, but also working on getting a really deep latch for those babies that are direct feeding. Assessment in how much they're getting. Can you hear a swallow? Can you see them sucking? As well as pain, right? We all like to say that a great latch should be pain-free. I say less painful to my patients, but you know that if there's sharp shooting pain, that's not where the baby needs to be, and really assessing the suck swallow as well as the pain-free latch. Hand expression, I can't say it enough times. Hand expression, I'm a fan. It is a great way to get that colostrum out early and start our setting up for our supply to be consistent. With referrals, they're going to be different process in each hospital. In my hospital system, if the patient is breastfeeding, says in labor and delivery that their desire is to have human milk to be part of their feeding pathway, they automatically get a referral to lactation services. Now, sometimes that means that lactation goes into this fourth-time mom who's breastfed all 3 of her previous baby, and the mom says no thanks. But oftentimes it means that this first-time mom, who maybe didn't even know it was going to be a struggle, has the opportunity to have help before she has to ask for it. So what is your process for your referral? When do you reach out to your lactation services, and what does that look like for you? Also, if you have babies that are medically complex, that have been in the NICU, for instance, for a little while, do you have a pathway for involving speech therapy in addition to lactation? Do you have a pathway for involving PT for babies who may struggle with not being able to open up wide enough? Do you have a process for making sure you're looking at the whole situation to know when you need to refer out for assistance? And then when you go home, that becomes another process for referral. Do you have a process for making sure that moms that are breastfeeding have close follow-up with their pediatrician for that baby? Do they have a resource to know if they get home and start having struggles they didn't experience in the hospital, what's their helpline? At my hospital, our lactation service has what they call a warm line. It's not staffed 24 hours, so they don't call it a hotline, but they try and get back to you within 1 to 2 business days so that they can be a resource for moms even once they're discharged who are having a hard time. Zip Milk is a great resource. If you guys don't know about it, it's Zip, Z-I-P Milk, M-I-L-K, zipmilk.org. And it is actually a web-based resource where you put in your zip code and it will show you all of the lactation support options that you have where you are. So it's definitely something that we talk to our patients about. As a tertiary referral, and sometimes I will get people who live in Jasper that deliver down in Marietta, and it's very far for them to come back. So being able to have an option to find them a resource that's closer where they live helps me support those patients that may need support once they're far from me. When you have families that are doing combination feeding, which I feel like is much more common in my patients these days, making sure that they have a good understanding about how production of human milk works. What I like to tell my patients is, I get it. You get nervous. The baby's lost more than 10%. You need to supplement for all of these reasons. But every time you feed the baby in a different way, you also have to remember to empty your breasts, right? Because the worst thing that we could do when someone who's struggling with supply is decrease the number of times that we ask for the boobs to empty. So that's a conversation. Hey, I like to tell my patients, your boobs are supply and demand. The more you ask, the more they'll make. So you have to ask more frequently, but make sure that if you have a partner who's helping with the bottle, or if you have a baby that's away from you, that you are still emptying your breasts on the same pattern or on the same frequency as the baby.
Thank you, Dr. Taylor. We don't have time restraints are kind of limiting, going through a lot about safe sleeping, but we wanted to include how rooming in is an opportunity to model safe sleep in this talk, because it is important and it is often bound up with feeding infants, right? Like when we're getting up in the middle of the night, what that looks like. So we just wanted to include that beyond teaching about safe feeding, all those different areas we covered about, everywhere from bottle feeding formula to bottle feeding express milk to combination feeding to exclusively breastfeeding. There's all that teaching that needs involved, but that can be wrapped together up with teaching and modeling safe sleep. So when you get the slides, you all know all the elements, but this can be connected with modeling an environment that the parents are going to be able to reproduce at home, keeping the baby in proximity to the parents for at least 6 months, and a lot of these elements around safe sleep. Okay. I think these couple are yours, Dr. Taylor.
So when we talk about rounding, and we were prepping for this talk, we were talking about kind of what it looks like, the differences between in the pediatrician service and in the OB service. And, as an obstetrician, I can't bundle all my patients into one room and walk in and go, okay, here's 414, here's 416, here's 418, right? I have to go to where the mom is. And so looking for opportunities for our pediatric team to do the same thing, to really look at this as an asset and a way to teach. If you have to go into the room to do the exam for the baby, then you have the opportunity to involve the family. Hey, this is what I'm doing. Oh, look, these are the cues that I'm looking for. Making sure that you also have an opportunity to field questions from the family, right? So many times mom will reach out to us and be like, well, my partner wanted me to ask, or my mom's worried about this. And this gives you an opportunity to not play that game telephone, but even as the pediatrician, to have face-to-face contact with the patient and the family to kind of reinforce the teaching, whether we're talking about feeding cues and frequency of feeding, or we're talking about safe sleep practices, to really reinforce the teaching that they're getting from the nurses and the ancillary staff. And you can see in a, ooh, too fast. And you can see And you can see as an obstetrician, because I work with residents, which are doctors in their training, I often travel with a gaggle of younger physicians. And so it gives me the opportunity to teach my residents and the families, hey, these are some of the different latches, right? Really looking as that in the room with the families, with the patients, as being an aspect. And I have to remember that just because the baby's out, I'm not done with all of the baby things. So making sure to incorporate talking about how's your latch feel? Did you see lactation? Don't forget you have to empty your breast often, and give them the opportunity for what their follow-up pathway looks like while we do that rounding and teaching.
Okay, so while we're speaking about family-centered rounds, I wanted to mention in the NICU as well. I've had the opportunity to learn from some great teams about the importance of family-centered rounds. Of course, NICU rounds should be open to parents on a regular basis, either they're physically or participating by telephone. There's lots of great studies even about going a step further and having family-led rounds, which I thought was a really interesting concept. But the idea of family-centered care in the NICU, and specifically about rounds, is using the physical exam and reviewing test results and the medical status of the baby to incorporate the parents as caregivers, helping them acquire that parental role and addressing their questions and soliciting their input when appropriate. And it's important and kind of a novel idea, but if you think about it, it shouldn't be, to be discussing the feeding plan from the get-go in the NICU, how the feeding orders are likely to progress, and connecting with the staff and the family about the milk, what I call the milk forecast. Like, do we have milk on hand? Are we using fresh milk when available? Are we using the colostrum first, the early milk? And then reinforcing, kind of teaching that role of mother's milk in the infant's care and the value of mother's milk to the infant's care, especially to a NICU baby. Addressing and being open-minded about questions parents have about nutrition, the importance of regular milk removal to establish that robust milk supply. One thing that I wanted to particularly mention is accommodating the mother's pumping schedule when you're doing rounds. I've had families that missed an important update. The mom missed the important update and had to get it from the other parent, or, things like that, because the mother was pumping. And it's really not fair to put a new mother in that position of like doing what she knows she needs to be doing to maintain her milk supply or missing out on important updates. So if mom's here but she's in the lactation room, skip ahead and come back if you can, and make sure that we're not putting her in that position. Pumping at the bedside is great when possible. That's another thing to incorporate. Some mothers are okay to just keep pumping during the rounds, and that's something that the nurse can be a good go-between there. And then family-centered rounds is another opportunity to refer parents to appropriate staff for needs that they have that come up, making sure that they're provided with support from lactation consultants, breast pump access, if they have, concerns that need addressed with the chaplain or social work, and just knowing that discharge teaching really can start from the beginning as part of family-centered care, and particular rounding in the NICU.
Okay, so we talked about, in a perfect world, all of our dyads would be together all the time and things would be rainbows and sunshine. And sometimes that just doesn't work. Especially when there's an unexpected C-section, the place where mom recovers is not going to be the postpartum room. So making sure that your system has an opportunity for that baby to go with mom to the recovery room, and that the staff can facilitate helping that mom breastfeed when she's awake enough and able to do it. Is there somebody there with her that can lift the baby? Is that something we have nursing staff that's available to do? Do we need to get lactation to come in the PACU to help with this golden hour latching? Or what if we have vaginal delivery that goes great, but then the infant struggles to transition and ends up in our temporary nursery to make sure that they're breathing well? You know, what is your process for making sure that that mom can come to where the baby is, or that mom has the opportunity to be supported in trying to still facilitate that golden hour and that latch whenever it's safe for the baby? You know, and when they're separated, especially when it wasn't planned or it was unexpected, making sure that in your process of caring for both the mom and the infant, that you are routinely looking for ways and opportunities to reunite that mom with that baby. Especially in the PACU, when baby's going to NICU, having that space, that physical space to pump, can be a big deal. So making sure that there are really just all of the bases covered.
Good point. I mean, that's kind of how we kind of got on this whole topic to begin with, was like there's rooming in, and we think of it as this very like precise thing that happens when a birth happens, but there's also applications like in a lot of different areas of the hospital, right? Like a nursing mother comes in through your ED. What are you doing to make sure that she can be with her baby if it's medically appropriate, and if not, that she's getting supported with expressing her milk? So we're going to do a little kind of top 3 concerns that come up about rooming in. And the first one is the parents asking for the baby to go to the nursery. So it can be helpful to have some scripting available and really talking through how to assess their needs, because you know, if our automatic response is like, no, in our hospital, you get to be with your baby 24 hours a day, that may not be meeting. There may be information that we don't know. The mother may be unwell and hasn't really communicated that. And she's worried about the safety of her infant or her confidence and ability to care for the baby. So kind of doing some scripting around that, and reinforcing some things that may be more of a myth, like, oh, I'm going to get more rest if I'm away from the baby, if the baby is somewhere else. And that hasn't really shown out to be true in the literature, but in an individual case, it might be true and important. So it's important to assess needs individually. You know, hearing what their concerns are, and helping that assess the safety, and reinforcing teaching and learning that may need to happen. And then if the baby is going to the nursery, to set some expectations about when the baby's going to come back, for how long, how the parents want you to manage feeding cues, and things like that, rather than just letting some unidentified period of time kind of go by without addressing how long the period is going to be that the mother and baby are separated.
And then reason number 2 would be when the mom isn't well. You know, what if mom goes home and then on postpartum day 7 comes back in with postpartum preeclampsia and has to be hospitalized? You know, what is your process? In our hospital, if they're not in the ICU and another adult can be with them, we encourage them to bring the baby also. We provide bassinets, we provide space for the baby in our other units. If somebody can transport the baby back and forth, if mom's well enough to hold the baby, or someone can hold the baby for her, you know, you maybe could have direct breastfeeding, even if mom had to undergo emergency lap chole and isn't feeling great. You know, if they come in through the ER, like Claire mentioned earlier, what is your process for identifying somebody who's breastfeeding and providing breast pumping supplies? You know, we have the process where we call and notify L&D, who hooks us into lactation and will help us work on getting pumping supplies in any of the towers we have in our hospital, not just our postpartum unit. You know, even if mom has to get separated from baby, are there opportunities for baby to come to mom to do skin to skin, which we know makes such a difference in our lactogenesis? What are your policies? Where do you think you could make your policies different? What are your policies?
Yeah, what is it? Right.
What are your policies?
That's a good point, because if you think about it, not removing milk can set a mother up for mastitis, pain, engorgement, and suppression of her milk supply. So if possible, having the baby breastfeed, even if she's not feeling great, can be easier than pumping, right? Like she may need support and help with, moving the baby, positioning the baby and things. But especially if it's a baby who is already breastfeeding well, it might be simpler and easier, at least for some of the time, to have the baby there directly breastfeeding. So kind of the third angle is if the baby is readmitted or is sent to the NICU or isn't well, it's important to encourage direct breastfeeding when possible. Kind of the flip side of that, it might be easier to directly breastfeed than pump. It can be easier to directly breastfeed than bottle feed, especially for an older baby who's got breastfeeding down and like is there for RSV, which we're seeing, have been seeing so much of, allowing the baby when they're well enough to feed by mouth just to go directly back to breastfeeding when possible. Of course, having your policy review to ensure that mothers of babies who are readmitted or who are sent to the NICU are automatically provided with access to an appropriate breast pump, but also supplies and teaching. Of course, we can't assume that anybody has ever even seen a breast pump in their life. They could have an exclusively breastfed baby who's readmitted and never have used a pump before. They may say they have their own pump, but it might not be appropriate. They may have just been pumping once or twice a day, and now we're asking them to pump exclusively. So having skilled evaluation and support there is important to include in your policies. And then, of course, going back to family-centered care, encourage holding and skin-to-skin kangaroo care whenever possible. And that's going to vary by staff in your unit, how sick, what level of NICU we're talking about. But doing all you can to, if mother can hold a baby, she can hold the baby skin to skin, right? Like if anyone's holding a baby, they can be held skin to skin, and it doesn't have to be taking off all their clothing. It can just be like having the baby's face on mom's chest. Like there's a big variety there. So doing what you can to operationalize that. And then of course, providing structural support like meals for parents, parking discounts, and then all the things we said about involving parents in the care of their infant if they are readmitted, and reviewing your policies, which we kind of keep harping on that, but it's important to take a look at.
And speaking of reviewing your policies, one of the cool things about getting to do this series of lectures is we want you to be fired up and be like, man, rooming in is so important. But sometimes walking away from the talk and not having a clear idea of what you can do next is hard, right? So this is our areas of opportunity that we think you should do next, right? Meet as a team. Who is your team? Is it the mother baby nurse? Is it somebody from lactation? Do you have an obstetric provider who can be a champion from the provider setting? Can you all sit down and take an opportunity to really do a global review of all of the different policies in all of these different places? We sometimes get focused, well, okay, I'm just mother baby and Claire's just NICU, but where are the places that these pieces can overlap and what does it look like? And to be honest, you're probably not going to be able to make all of your policies the perfect policies starting tomorrow, although good job if you can. But can you at least move the attitude a little bit? Hey, gosh, rooming in doesn't have to be this very narrow conscripted idea of what I thought it was. Let me see how I can shift our attitude in our institution to look for more creative ways to facilitate moms and babies being together more.
Yeah, we did a webinar earlier this summer on the organizational iceberg. If you didn't see it, the recording's available on Teams and on the GaPQC website. But Dr. Fairley and I kind of reviewed this idea that sometimes it's shifting attitudes and behaviors is more important than what's written down in your policy. So we want to kind of encourage you all with these action items. So like Dr. Taylor said, gather your stakeholders. Who are those? Is it just the people you've identified to be on your team, or would it make sense to identify some key stakeholders to add either to the GaPQC team or just for a discussion around particularly this topic? Sometimes it can help to really identify folks who may be naysayers around this and hear them and hear what their concerns are so that you know how to address that. Because if there's somebody who's saying those things, there's other people who are thinking it. So it's important to find out, really hear from the broad variety and not just only line up who you think are your champions around things. So then review your policies and procedures, look for gaps. When are mothers and babies separated, and why? And are those rare reasons or really common reasons? If most of your staff are really on board all together now, that's great. You can kind of focus on the outlier situations. If not, you might need to start with the most important or most impactful changes. So prioritizing what your challenges and gaps are, and then make a plan to address them and use the PDSA cycle to plan, do. Now I'm like, I was just telling Dr. Taylor, we were talking about PDSA, plan, do, now I'm like forgetting it.
Sorry.
Yeah, you made me think about it too hard. Plan, somebody I can unmute and say what it is. Plan, do.
Plan, do, study, act.
Study, I'm like.
Of course, you guys passed, good job.
Extra credit. Plan, do, study, act. So making that cycle that you're continuously improving and choosing options that are going to be either easy to do and keep piling up all your easy things and you're going to move the needle, or find some of the more impactful things that are doable and focus on them. And that's going to be really different for different units and different hospitals participating.
And sometimes those assets come in places you may not be looking for. When we were trying to figure out how to better identify postpartum moms that were breastfeeding that came in through our ER, our staff that comes through and helps register the patients turned out to be a huge asset, because they were totally fine with rolling that into that series of questions that they asked. And I had never thought to involve my clerical staff, but when they do the, where do you live? Who's your insurance? Who are you here with? Have you
Are you breastfeeding a baby?
6 months? Yeah, right. It's no big deal for them, but that was a huge asset for identifying that patient segment that we hadn't been able to easily identify before. So where are those places that may not be the most obvious that you can find someone to help you get these patients identified?
So, I cannot see the chat box, so I'm gonna see if Deb or Laura can share if anyone has questions, or you guys can unmute and ask some questions. Dr. Taylor's been living this in the hospital and is a great resource. And then some of you, I put answers to, because some of you might also want to share what you've done to address this, even if it wasn't in a formal, organized way through the initiative. Anyone?
Hey,
not everybody at once.
Can you hear me?
Yeah.
All right. So this is Casey Nation. I'm from Eggleston's NICU.
Hi, Casey.
So while we're on this topic, I just want to say that I've never worked in another NICU in the city, just in Eggleston's NICU, but I do know people who do work in other NICUs throughout the city, and or have had kids in them. And on this topic, I really want to encourage the other NICUs to really look at, like you were saying, like why the points at which you're not allowing parents to be at their baby's bedside, and really consider, like, is this really a point where we can't have the parent at the bedside? And like, is the detriment to the baby and the parent worse for separating them than the detriment to whatever is happening in the unit at that time? So like at Eggleston, the only time we really ask the parents to leave is if we're doing a bedside surgery in the ICU part of the unit. And like I said, I know other people who've had kids in other units, and just the things I hear, I'm just very concerned. So I just want to encourage you guys to really, look at what you're doing, and if it's really evidence-based, and see if there are better ways that you can support your families.
And I think, Casey, that's a great way to look for easy changes to make. I like, this is one of my passions for many reasons, but I had twins at 30 weeks that spent 8 weeks in the NICU. And so while I thought I was familiar with the NICU as a obstetric provider, I now know more facets to it. When my kids were in the NICU, and this was several years ago, we were routinely asked to leave during rounds. And that was for an hour a day, twice a day. And so as we've gotten more to pediatricians doing bedside rounds and for NICU staff doing family-centered rounds, is that a place where at my institution we could make an easy change that would facilitate family-centered care in our NICUs? Aubrey, who was going to be one of our presenters today and is busy admitting babies, was talking about they were super excited because now they have a dedicated breast pump at every NICU bed. And that was huge, right? You don't have to wait your turn. You don't have to go to a lactation room, but being able to have the resources that the parents need to stay bedside if they're comfortable with it is another easy, a little expensive, but easy way to really push on this idea of family-centered care. So yeah, 100%, that's something we could look at.
Yeah, thank you for speaking up, Casey, because I think just like any changes, I mean, anyone who's been in the healthcare field for a few years knows like, oh, we used to do X, Y, and Z, right? Like we used to round up, we used to send all the babies to a nursery and you would come look at them in a window. And we've made a lot of changes since then, but I think things like, during shift change, if a parent is at the bedside, can they just stay there during the shift change? Like probably yes. Like what is really the problem with doing that? That they're going to hear the handoff? Like that's good. You want them to hear the handoff. So things like that can be, it's important. And you're right. It's, that especially like shift change, that's a time of day a lot of parents can get to the NICU, right? So if we're routinely excluding parents from and families from the NICU during that time period, like does the benefit or ease or convenience of our staff really outweigh the inconvenience to the parents? And it affects the parents' experience, whether they feel welcome in the unit and at the bedside. Any other questions or answers? Well, we hope that this will be helpful to you guys and you'll be able to take it back to discuss among your team. If you haven't been meeting regularly with your group, that's something we recommend you do, whether that's by email, twice a month, once a month after or before this meeting. However, if this time of day doesn't work for your group, finding another time where you can review the recording or asking people to watch the recordings and meet up afterwards. It's going to look different for different units and different size units and different, if it's a mother baby versus NICU, are you doing active improvement or just the learning collaborative? But even if you're not in the active improvement, we hope that those of you involved in the learning collaborative will still take some of this back to your team and your unit and think about changes that you can make to optimize newborn nutrition. Laura, did you see it? Did Dr. Patel, was he able to join? I know he's on service today.
He is. He's on.
Dr. Patel, Kimberly mentioned that you had some reminders if you're able to join.
Claire, I can just go ahead and give the reminders, and
Okay.
if Dr. Patel is on, he can jump on behind me.
Yeah.
But yes, thank you both so much. Dr. Taylor, Claire, you guys are just such a wealth of knowledge, and we just really appreciate you taking the time to be here and talk with our teams today. This is so important, and I know it's things that they will be able to carry forward and improve for their hospital, for their teams and their babies. So just a reminder for everyone on the call that the November audit is November 21st. And you will be receiving quarterly reports very soon, and you all can take a look at those with your teams. That'll be a good starting point. And then we will start focusing in December on the quality improvement tools and the process. And that will help you figure out where you are and the steps you can take to make improvements. So if anything comes up, we're here. Please reach out. And we just really appreciate you all taking the time to join today and everything that you're doing for babies in Georgia. And again, thank you to our presenters. If there's anyone else, so Dr. Patel or Dr. Levine, if you're on and had any comments, jump right on in.
And don't forget to vote today. It's the last day. Make sure you vote.
Yes, absolutely. Take time for that. All right. Well, I hope you guys all have a great day and rest of your week. And we look forward to seeing you in December. Bye, everybody.